Oh, okay. So next is, sorry, next is Helga Sandoval, a dear friend. Helga works with Carrie Solomon. She's the Director of Research at the Carolina Eye Care Physicians and is an adjunct professor of ophthalmology at the Storm Eye Institute at Medical University of South Carolina in Charleston. She's worked with Carrie Solomon for the last 17 years. And for many years, Dr. Solomon and Dr. Sandoval's practice has probably had some of the best refractive outcomes in the world. For the last 15 years, I've been looking at physician databases. We're up to 280,000 implantations, and this practice is one of the top 5 practices in the world for outcomes. Dr. Sandoval has over 45 peer-reviewed publications and has given more than 150 presentations. And what she's going to share with us is some of her initial data with version 2 of the RBF calculation method. Dr. Sandoval.
Thank you, Dr. Hill. Thank you to everybody for being here this time. And yes, I'm going to show you the process that we currently have using the the Hill RBF formula to see how you can get to where we are. This is my financial disclosure, nothing relevant to this presentation. So here is what we have. We currently have the LensStar, and we have version 1 of the formula. And we have aligned the lenses that we currently use for the Ascend 60WF. We have the Haigis, the Barrett, as well as the Olsen and the Hill RBF. And we compare, we make sure, as Dr. Snyder's nicely showed, that all the measurements are consistently, and if we see a difference, we confirm that that difference indeed is there. And we compare the powers. You can see a difference maybe of a half diopter between the different formulas, but if you see something more than that, something is going on in there. But now, version 1 doesn't have the capability of doing monovision or any other target than plano. So in that case, when we have these patients, we go to the online calculator, and we just enter the information as it is required. And then we can have here our measurement for a monovision patient. And here we can see the printout from the online calculator, very similar to the printout that you obtain from the LensStar, but now we have our patient's calculation. One thing that we love about the formula is if there is a measurement that it doesn't make any sense at all, it warns us that, the measurement is out of bounds, that we should be careful or not to use that power based on the formula. Now here are the outcomes. So here we start working with Dr. Hill back in 2014, 2015. This is the results of the retrospective study that he did. And at that time, we were with the monofocal lens about 97.5 within half diopter of the target refraction, and 95% with the toric lenses. Now here is where we are 3 years later. Our outcome within half diopter is 98% with both the monofocal lens and the toric EDOF lens that we are currently using. And our outcomes at within quarter of diopter are steadily improving as well. All our patients are 100% within 3/4 of diopter of the intended target. But how we get there? That is the question. So the first thing that I will recommend you is track your outcomes, but track the numbers. Don't think that, okay, my patients are happy, I'm doing good, that's good. No. Track your outcomes, know where you are, and define where do you want to go, where do you want to be. Now, the other key, as it has been stressed during this presentation, is the preoperative measurements. You need to have a very good biometer like the LensStar. You need to make sure that the surface of your patient is healthy. If there is dryness, dry eyes, you have to make sure that you optimize that ocular surface before you actually do the measurements for the surgery. Use the validation criteria, as Dr. Snyder said. Make sure you train your techs to do that properly. And repeat. If you're not happy with the measurements, repeat. I can tell you that I'm the tech least favorite person in the practice because I make them repeat the testing. Unfortunately, patients have to come back for that purpose, but it is their outcome at the end of the surgery. And then, of course, the IOL power calculation formulas. We have to have modern formulas to get to better outcomes and to provide what is best for our patients. But now what is the next step? Can we improve our goal to quarter of diopter, increase that percentage? Probably we could do with the modern technology, new lenses, new things coming up in the market. I think that can be done. One thing that I also wanted to say is there is a difference. We just finished a multi-center study using a toric EDOF lens. Of course, it's a study, the protocol is the same, all practices have to follow the same criteria. We were expecting to see the outcomes of all the sites about the same within that half diopter. And we have one site that is at 78%, while we got 98%. So why is that difference? We are using the same formulas, we are using the same device, why we have 20% difference between these outcomes. So again, preoperative measurements, validation criteria, and repeat as if you need. Thank you for your attention.
Thank you, Helga. In the last few minutes, I'm going to just share with you some things that may be transformative in ophthalmology. What's happening is we've all seen the calculation methods getting better. Barrett was really transformative for us, and I think the RBF method may have something to add as well. But industry is also responding right now, and we're starting to see rumblings of exact IOL powers by hyper-accurate methods to within 1,000th of a diopter. This is off-the-shelf technology. And then the keratometry may be getting better and better and better with newer methodologies. And I think when these two things begin to happen, we'll see another incremental change. So again, this is an exciting time for ophthalmology. We now have calculation methods and measurement technology that's very, very good. And in my opinion, if your half diopter accuracy that you track is less than 90% with the LensStar and the different measurement technologies and calculation technologies available to you, you're probably doing something wrong. So this is completely achievable right now with current technology. So I want to thank all of our speakers today, and to all of you for taking time to be with us, and I hope you have a good meeting. Thank you.